I'm going to be very emotional this morning. For the people who don't know me, I'm not a morning person, but I am very emotional having this view of this room. When Dr. Bug asks you to do something, you do it. And my deep amount of love, honor, and respect for her and what she's built with everybody in this room is really overwhelming this morning. So it's such a gift to be able to be here with you all. A couple of things. So some of you may have heard a rumor that I'm no longer at the University of California, San Francisco. That's actually not true. I returned to the adjunct series because I will be joining the faculty at the University of Washington as a full professor on September 16th. And I'm lucky because I'll be a full professor in both the schools of nursing and public health, which I think is super important in this current moment. So y'all know me, and I know y'all, and I love y'all, and thank you to the people who are watching online, and particularly I need to shout out Dr. Ifeanyi Asiadu, who I know is loved in this room, right? Who not only was promoted to associate professor with tenure, but she was accelerated in light of her incredible visionary vanguard work. And I'm just so grateful to be here and to be in this room where I know she is deeply loved and respected. I also want to be able to shout out my good friend, Dr. Joya Creer-Perry, who I know will be flying in later on today. I'm very excited that she will be here at 4 o'clock and will be addressing you tomorrow morning. It is very important for me to stand on the shoulders of our elders, but in addition to, with the people who are doing some really incredible work. So I'm going to talk to you about it. I didn't prepare a ton of slides because I already see some questions in the Hoover app that I want to talk about. It would be impossible for me to speak about anything in this current moment if I don't bring up Dobbs, if I don't bring up Roe, if I don't bring up crisis pregnancy centers, if I don't bring up the fact that we have student loan debt cancellation that happened yesterday, if I don't get on criminalization of pregnant people, if I don't get on the removal of voting rights, and connecting all of this to reproductive justice. And I have to say, I'm pretty sad that I can't stay here with you all for the whole meeting because your agenda is incredible. There's some really, really powerful and brilliant people in this room. But unfortunately, our colleagues at Sister Song decided a couple of years ago that their Let's Talk About Sex meeting, which happens every other year, was going to start tomorrow. But you have such an incredible agenda. I've been through it. I will be watching some of it through the Hoover app because you just have some really great content that's planned. And where are my time, people? Because I have my time on my phone. Who am I looking at? Oh, great. Thank you very much for doing that because I could talk about this all day. But I want to take some of the questions. I want to address some of the comments that happened in the app. And then I want to take some from the room because we're in tricky times right now. Right? I mean, we have a situation where we are about 3 months out from a midterm election. We, have a very, very sort of volatile Congress and House. We have a situation where voting rights are actually being discussed as if they're not actual human right. And I don't have to tell this room our maternal morbidity and mortality crisis is still not being impacted or affected despite the hard work of the Congressional Black Caucus. I mean, how many people in this room were still really angry that Momnibus was not included in the, recently passed bill around inflation, right? I mean, we're angry about that. So this idea that we are not in really tricky times, I want us to hold on to that thought because I think that it also affords us a very interesting opportunity to go rogue, which is what I said yesterday on my Twitter feed. Before I start, you have my affirmative consent for photos and slides. I will share these. You have my affirmative consent to use social media because I have said this often and I will say this everywhere I go. If Nazis, bots, and trolls are the only people who are using the tools of social media, then we can't be mad when misinformation runs rampant. So, if you don't know me, I am a person who feels very strongly about positionality. Not because of identity politics and not because it's to, somehow normalize Black women speakers at, any kinds of events. It's so you know where I'm coming from. And I can be very upfront about where my focus is. I can be very upfront about, where I sit epistemologically and ontologically, or how we know things or how I know things. And I can be very clear with you about what I mean when I say things. The most important point, though, on this slide is that I was enough at Black woman. It's really great to be able to read all the accolades and all those different things. But Black feminism teaches us that I actually was really enough at Black woman, and that positionality affords me a unique perspective through which to be able to share my experiences, my knowledge, and my life. Right? So the more that we normalize that, I think the more we can get beyond some very complicated discussions that are grounded in people's feelings, that's personally developed to keep people polarized, right? That's an act of laziness. Putting people on two different sides, right? I'm pro-life, I'm pro-choice, everybody gets in their feelings, everybody starts yelling, and then we can't have an adult, nuanced discussion about a difficult topic. Right? That's purposive. So we need to disrupt that piece. And as people who work at the edge of public health, clinical health services provision, that's what lactation and human milk feeding and chest feeding and breastfeeding folk, y'all are everywhere. You're like that glue, right? So you're not just at the episode of birth. You're not just in hospitals. You're with families before babies come. You're with families after babies come, right? You are with people in real time. So sitting at that intersection between public health, clinical health services provision, policy, education, right? Your work spans all of that. So if nothing more, I use positionality to hopefully to activate this audience, because part of the power of what we need in order to change our world, to change health outcomes, to change the lives of the people that we work with, sits in this room. So let me get you all on the same page, and I sent this to Joya. I sent my slide sets to Joya because I told her, I was like, I'm going to use one of your favorite slides today. She said, you go ahead and do that, Monica, because I might use it too. So this is it. When we're trying to talk to people and explain to folks why it is so important that we not just focus on social determinants of health, and I purposively did not put any connotation about these social determinants of health. People always talk about them like they're negative. They're not, actually, right? Whether or not we have transportation, whether or not we have student debt loan repayment, whether or not we have safe schools, whether or not we have availability of food, these are policy decisions. They didn't just fall out the air, right? So inherently, social determinants of health are not positive and they're not negative. They're neutral, right? The lack of availability of food, the lack of transportation. Transportation in and of itself is a good thing, right? So when we think about it, but too many people, I think, all right, I'm gonna use this pointer because that would probably be better. But like too many people see here, like these just show up and then health outcomes are impacted. But if you look at this grid, if you start at the bottom, you will see that there are disparities in the distribution of disease, illness, and wellness. There's disparities in the distribution of wellness. Let me say that again, right? Well, where does that come from? Well, if the social determinants of health don't drop out the sky, we can move up to the next level, which is this level of power and wealth imbalance, right? We have labor markets, we have housing policy, we have social safety net, we have social networks, we have tax policy. All of that, it doesn't fall out of thin air either. That actually comes from institutional racism, class oppression, and gender oppression, and gender hierarchy. Right? These things don't just appear. They actually are born from policy decisions. They're born from procedural decisions. So we can make different decisions. Social determinants of health are a result of policy decisions, is my take-home point, and health disparities arise from structural racism. Health inequities persist because of structural racism. Like when I say this to people, if we really wanted to eliminate, reduce, or ameliorate health disparities, we could do that with some very simple interventions. We could guarantee our citizens a basic minimum income, right? We could stop incarcerating people. We could cancel student loan debt. Like, so we could do these things, right? Especially in the context, the thing that got me yesterday that was so powerful, and I don't know who else's social media feeds and other kinds of like emails were blowing up around the student loan debt thing. But it was announced earlier in the morning, and this is one of the benefits of living on the West Coast, that we were sending a new $3 billion package to Ukraine, right? So our total now is $12 billion. And I would like to argue that we invest that $12 billion in our like citizens here in the United States. Right? I mean, and so to me, we get in, again, this very bipolarized, like, sort of feelings. Oh, we can't do that. Oh, national deficit. Why do we only talk about national deficit when we're talking about money for our own citizens? Right? So we need to shift the conversation. We need to change how we talk about these things. We need to make space for very nuanced and difficult conversations. And the reason I think that lactation individuals and professionals who work in breast and chest feeding and human milk and all of this is because you sit at a very unique intersection where people are making a huge transition in their lives, right? As a nurse, that's what I feel like my core work is. I help people manage transitions, right? From wellness to illness, from sick and death and dying, or to, recuperation and rehab. That's really the core work of nursing, which is very similar to the core work that you're doing, right? Managing transitions. I mean, I try to explain to people all the time. People focus on pregnant people and, babies and offspring. What about the relationship of the co-parents? What about the other children in the house? These are things y'all pay attention to, right? So as we think about activating our thinking and the work that we want to be able to do and the theoretical underpinnings that really push our work, I'm pushing y'all to be bolder. I'm pushing y'all to be more loud about your work. That's why conferences like this are so important. I wish the people online could see this room because it's incredible. The potential, right? The actual work that you all are doing. We can make this disappear. And I need more people to believe that. This is a framework, real quick, just a couple of slides to walk you through how to talk differently, not only with the people that we serve, but at the institutions that we work with, that the public health departments, the hospitals, the healthcare facilities, rehab, whatever it is, we need to have different conversations with ourselves. And so part of wanting to activate you all, this is something I learned from my good colleague who also is in the room, Joanne Allen, who I'm so excited about getting to meet in person. I've been working with her for 3 years, and this is one of those fallouts from the pandemic that you actually get to see people in person that you've been working with Zoom on for years. But she taught me that one of the things that we have to do is when we've tried to have conversations with people over and over and over again, at some point you gotta try a different strategy. Right? At some point, you have to use different tools to move people. So as I was thinking through during the pandemic, one of the things that I kept thinking about is we're not all having the same conversation. It dawned on me, like I was sitting talking with public health practitioners as part of the American Public Health Association. I was like, we're not having the same conversation. I'm reimagining, and they're still here trying to retrofit what we already have. And it was very fascinating to think about that in real time. So I want to give you some quick language to be able to not only identify when this is happening, but also how to disrupt it. Because this is why we can't, in our program planning, in our grant applications, when we're trying to do education and teaching, when we're trying to work on policy, this is where we get gummed up, because we're not recognizing that some of us are trying to retrofit something, some of us are trying to reform it, and some of us are trying to reimagine it. And those three things require different strategies and different skills. I published this open source in the Journal of Perinatal and Neonatal Nursing so people could have it, because I just got, I would present it and talk through it, and then people would use it in activities. We did it at City Match and March of Dimes, and they were like, we need a paper on this. So I finally got it published. I was really excited about that. The next 4 slides come from the Merriam-Webster dictionary. They are nothing special, right? And they're not even mine, okay? Because I believe in definitions. When you look up the word retrofit, and I spent the last 30 years in California, I now live in Seattle. So for me, retrofit has a very specific meaning because of earthquakes, right? But when you think about the word retrofit, I like the bottom definition. I'm going to read it for you. It says, to retrofit is to adapt to a new purpose or a need, to modify. So an example is you're retrofitting the story for a new audience. The reason retrofit is really important, and this definition is really important, because there's a huge inherent assumption in retrofit. And that huge assumption is that the inherent structure is not going to change. Let me say that again. When you're retrofitting something, the inherent structure is not going to change. So when we think about like payers in healthcare, and we think about the fact that it is driven by insurance in the United States, whether that's public insurance, what we call Medi-Cal in California, or Medicaid, or Medicare, or if it's employer-sponsored health insurance, which most is, which is also heavily government subsidized. That's why I don't use the word private insurance, because it's not private. It's an employer-sponsored, and it is government subsidized. So when we think about insurance as a payer driving many of these decisions, a lot of us are trying to retrofit lactation services, right? Because who's paying is not inherently going to change, right? At least not yet, right? So that's a retrofit. And for people who want to have alternative payment models and doing all this sort of rearranging chairs on the Titanic, that inherent structure is not going to change, right? Until we have a different payment system, or we can have different conversations about how care and who is paying for care. That inherent structure is going to stay the same. So we can't keep trying to reimagine, oh yeah, we're going to be able to have a single payer, national payer. It's got to be a both and, because that inherent structure of payment is not going to change. And until it does, we need to put those steps into place to make that a thing. Reform has 4 different definitions in the Merriam-Webster dictionary, and I like the first one. And the reason I like the first one will become very obvious to people who work in clinical environments at this meeting. It says, reform is to put or change into an improved form or condition. The B definition says to amend or improve by change or form or removal of faults or abuses. How many times in healthcare do you see the word removal? We always add something, right? Like you get a new policy, you get a new procedure, you get a new technique. We never remove anything. It's always additive, right? Because we are worried, we're concerned, it's historical, right? Whatever it is, we don't give people permission to stop doing things that no longer make sense, right? So one of the things that I like about this reform definition is it allows you to remove things that are no longer working, right? It also allows you to change things. So we have too many people in the universe who don't think that our current situation can be changed. I'm not one of them. And I'm hoping to have a coalition of the willing in this room of other people who reject the fact that we can't change things, right? But we want to be able to change, we want to invest our energy in the things that we can change. We don't want to live in retrofit trying to change certain things that are not going to change, at least not immediately. That's a waste of energy. That's where you get people burned out. They don't want to do the work no more. Oh, we've been doing this forever. Right? We want to get to a place where we can change things. Too many of us live on Team Reimagine. And I know I'm guilty of this, so I'm not calling nobody out, right? Because this is what we want, right? I mean, if you can't see that, I'll go ahead and read it. To reimagine is to imagine again or anew, or especially to form a new conceptualization of, to recreate. Start over, hit the reset button, blow it all up, right? We live on Team Reimagine. What's the problem with Reimagine? No accountability, no community. We can live and dream and daydream in Team Reimagine all day, and nothing gets done, right? What painfully came to mind for me as I was working on this framework is 3 things. The first is retrofit, reform, and reimagine are a circle. They're not a line. And we need all three at the same time. Let me say that again, right? It's not a linear process. Retrofit, reform, and reimagine, it's a circle. And different people will be in different conversations on different domains of the circle. The other issue around retrofit, reform, and reimagine is we need all three at the same time. Another way to think about this is retrofit can be past, reform can be present, reimagine can be future. Another way to think about this is retrofit is reproductive health, right? Reform is reproductive rights. Reimagine is reproductive justice, right? So if we think about like reproductive health, that's the health services provision. You go in and you get your breast exam, you get your pap smear, that's reproductive health. Reproductive rights are the legal protections that citizens have to be able to operationalize their reproductive life course, right? The fall of Roe was about reproductive rights. It affected reproductive health, but that was really about reproductive rights. Reproductive justice is a completely different theoretical framework, advocacy tools, praxis, strategy that reimagines both reproductive health and reproductive rights in a human rights and social justice lens, right? It posits that every human has the human right to decide if, when, and how to create family and kin, if, when, and how, and where to birth, if, when, and how to end pregnancies, to prevent them, right? It gives us a human right to parent the children we already have in healthy and safe environments, right? Free from criminalization. It allows people to not have to be forced to give up parental rights if they are disabled or incarcerated, right? It's a more powerful tool than reproductive health and reproductive rights combined. So when we think about this retrofit, reform, reimagine, when we think about this current moment where we're at, I am hoping to activate you, and I'm using that word purposefully to get your spidey hats and senses tingling in the back of your neck to really think about, we need to unlock the creativity of the collective if we are going to get through this current moment and keep as many people healthy and safe as possible. So that's the real purpose of wanting to make sure that the lactation community, human milk feeding community, because y'all do way more than that. Can we just get on that? I am just so done, right? And I say this in the oncology world as well, but y'all do so much more than make sure that human milk can get to infants. I have seen, lactation consultants who do family counseling and therapy, right? Some of y'all extend into really doing intergenerational resolution of trauma. Some of y'all do day-to-day harm reduction as an essential part of your work. Don't think we don't see you. I see you, right? And so I'm going to use the platform that I have to make sure that others see that you are doing all of this. Right? And to recognize you as unique partners in the work that we are trying to do, which I believe is a retrofit of improving health outcomes. Let me say that again. I think improving health outcomes is a retrofit because I think we can do better, right? Resolving health inequities and health disparities is a reformation. That's not reimagining. Reimagining gets us to a place where people can thrive, and we're not actually trying to bring along the people who were never included in the first place, right? So as we think through and as we continue to build the futures, plural, that we want, we have to think about the decisions that we're making in the now. We have to think about the investments of human, money, and space, and time, resources. Now, I want to talk you through another piece to this that I think that's really, really important. I already said that. Is this issue of combating disciplinary elitism that causes harm, right? I've been writing a lot about this recently because I am just, I've been a nurse for, I don't know, 30 some odd years. And I am done with healthcare hierarchy. And I'm really done with people who, who hold power, because holding power is not helpful, right? You have to either share it, wield it, or give it up. Because if you're going to hold power, then that means you are constantly going to be sitting on team retrofit. And that's not helpful for those of us who want to reform and reimagine. So when this paper came out, and this is no diss to the authors, and this is no diss to the people who are on the paper, because I actually think it works, but it also exploits some things that I think is not really helpful. This is Lisa Cooper and her team. She's a MacArthur Genius Award winner and is at Hopkins. They wrote this paper called Distinguishing Workforce Diversity from Health Equity Efforts in Medicine. And this is one of those situations where it gets really tricky, because I always have to remind people that medicine as a discipline does not represent all of healthcare, and that they have to be very careful when they write things like this, because some people do conflate medicine with all of healthcare, and that includes nursing and lactation and physical therapy and dentistry and pharmacy, right? So one of the main arguments in this paper is that you have to distinguish your workforce diversity efforts from health equity efforts. And it would make sense in a discipline like medicine for them to write something like this, because they are contractors with the service providers of healthcare. I always have to remind them, nurses are employees, right? So when we think through our philosophical orientation about health equity, in my mind, workforce diversity has to be an essential component to that. Let me explain why. In the paper, they talk a little bit about this confluence between equity, diversity, inclusion work, and thinking about the larger community. That's where y'all are, that's where we are, right? Disentangling this conflation could adopt more effective approaches, incorporating the appropriate and distinct expertise and infrastructure, leaders that are necessary to tackle these unique institutional and societal problems, right? This is where, when you only work in the episode of hospitals, that you don't have a 30,000-foot view about what's necessary. This is also an issue where we don't see the people that we serve as part of our future workforce. And I actually reject that, right? So if we really wanted to apply retrofit, reform, or reimagine to a situation where we think workforce diversity is not necessarily related to health equity and health outcomes, well, one could say a retrofit is we could make sure that we do incorporate all the necessary infrastructure and leadership tools and money that we need to tackle social and institutional problems. A reform could be, well, okay, yeah, let's adopt some more effective approaches. And to reimagine, well, we could have some transdisciplinary team-based approaches that don't reify existing healthcare hierarchy. We could all come together, recognize our unique contributions, and be able to come together with new strategies, new ideas, new services, new programs, partnering with community members, and determine whether or not that improves health outcomes. They made 8 key recommendations in this paper, and I think this paper is really important for a variety of reasons, but they wanted to clarify leadership roles. They wanted to appoint people with very specific expertise and leadership skills. They wanted to really, really think through, the resources that were necessary, capacity building, making sure you're giving people credit for the work that they're doing, and using rigorous, evaluations to make sure that the institution's mission is being operationalized. As lactation consultants, as human milk feeding experts, as breast and chest feeding professionals, as people who sit at the intersection of public health, clinical health services provision, policy, education, one of the things that I want to really get us to start thinking about is we can't keep allowing individuals and disciplines to consolidate power. Right? This is a real fundamental issue in our current moment. We have to think about a both-and approach when we are talking about workforce diversification and when we're talking about equity, diversity, inclusion, and when we're talking about health outcome. And we have to be real clear when we are talking about health services provision and language. I wrote about this in a book with 36 other Black people, which I was really lucky to be able to do, called The Black Agenda. And I stand by this quote, and I will say it everywhere I go. That even more frustrating is the fact that our exclusion, that's the exclusion of Black people, from the health professions is part of a long history of discrediting and defunding Black people who have aspired to join the health profession. And what I really think we need, and this can really come out of lactation, is we need healthcare reparations, right? If we can cancel student loan debt for 43 million Americans, then we can guarantee any Black, Indigenous, Latinx person who lives within a 20-mile vicinity of a healthcare or health-providing institution to have debt-free education to join the health professions, regardless of what discipline they want to join, for the next 50 years. Just saying. So when we think about power, and when we think about healthcare hierarchy, one of the things that has always driven me up a tree is that lactation, human milk feeding, chest and breastfeeding is not a default service. Why is it still a referral service? Can we ask that question? Right? Because what's the inherent assumption in that? Right? I mean, yell it out. What's the inherent? Why is like that there's a problem? Right? Or that it's easy and people will just be able to do it. Right? Who's from the 80s with me and remember, just do it, right? From like, right? Just be able to do it. So it's a rethinking of this notion, right? Everybody can roll midwives and doulas off their tongue as, trying to help maternal morbidity and mortality. Maybe we should include in that lactation and chest and breastfeeding, human milk provision. Right? We need a thing that will, like I've been practicing so I can roll that off my tongue, right? But we need some language around that so that that's included. And that the default isn't that people are ultimately going to be taught by somebody, whether they've had educational exposure training or not, that they'll be able to do this. And that is only if there is a problem or only if there's some issues will we expand the expertise of people in this room, right? At some point, we have to flip that on its head as part of a default set of services that are just afforded, that are just provided to people. And we have to make investments in that. And I want to base my argument for that on this one very simple principle. We had a diverse workforce, right? What's the name of this conference? Right? The theme of this conference was on the main slide. It's all over the imagery around this room, right? We had a diverse workforce. The Black Grand Midwives took care of everybody and had relatively good outcomes at the time when they provided care for enslaved and non-enslaved persons on plantations. We had a diverse workforce. It just didn't happen to be physicians or nurses, right? And so when we think about rebuilding, remaking, reimagining, retrofitting our workforces, we can be thinking through this idea that the greatest untapped, unreleased workforce that we can have are the people we serve. Building programs for people who have lived experience of pregnancy, birth, miscarriage, infertility, lactation. They have lived experience, they can be taught, right? I created a project with some very incredible doulas in the Bay Area that train formerly incarcerated people to become birth doulas, because we already knew that 88% of incarcerated persons who identified as woman or female were already parents. Our big goal was to make sure we weren't re-traumatizing them by bringing them back into hospitals and healthcare institutions. So that required having specialized training to make sure that they themselves would be well in order to be able to care for others, right? We had a diverse workforce. We can have another one. But I need more people to believe that, right? Because if we believed it, then we would create policy and have actions that would allow us to operationalize that, right? When diagnoses and treatment are not enough, medicine does not speak for the rest of healthcare. I think it's super important that we think about this issue of concordance, right? I know people want to slink away from this because, oh, does that mean we need quotas in healthcare? And oh, does that mean only black people want black people to take care of black people? Yes, right? I mean, right? But nobody asks that question around concordance when you don't have to. Why is it only asked of minoritized communities or people racialized as black? Right? The flip question to that, the reform question to that is, as a white person, do you have to demand having a white person take care of you? Right? Why is that not a question in your universe? So for me, it's this bigger discussion because we know that there are harms that are occurring. And I'm not just talking about death and dying, right? The thing we don't talk about enough when we talk about maternal morbidity and mortality is morbidity. Right? I always say to people, you know, Serena and Beyonce, they lived. We would not classify that as a mortality. We would class that as a morbidity, right? And we already know that we are undercounting and underestimating maternal morbidity because the ProPublica report in the Lost Mothers series, their estimates were at 50,000 a year. Now, when you think about that, we know that's more, right? Whoever said that, amen. Right? Because if we have an estimated 4 million births in the United States, just think about this. If we have estimated 4 million births in the United States, and prior to the fall of Roe, we had about 800,000 abortions, right? That means there's almost 5 million pregnancies in the United States. So if you think that 50,000 of them might be a near miss, that's a huge proportion of the population that's living with morbidity. Yeah, you live at the end, you might have a live baby, but who's dealing with that trauma? That's y'all, right? And the mental health providers, right? We need more of them too, right? But as we think through this, we have got to stop planning and spending our money around the episode of birth when we know pregnancy is 9 months and we know postpartum is forever, as Alicia put. Parenthood is forever, right? So I need us to start thinking differently about this. This is both and. I'm so excited I got to take these pictures because, you know, this is Dr. Nakia Grayson. How many of y'all know her from Choices in Memphis? Nakia Grayson in the middle, who took our selfie. That's Dr. Grayson. If you don't know her, she's a DNP-prepared family nurse practitioner. She's also a certified nurse midwife. And she runs one of the most innovative health centers in the United States. It's called Choices, and they now have to change their name because it was Choices in Memphis, but now they're opening a new clinic in Carbondale because today, all abortion services, and there's no exception for rape or incest, end in the state of Tennessee, and they are a full spectrum birth, abortion, family planning. They are also managing a panel of, 200, 300 trans-identified individuals in the Rust Belt. They're having to move their abortion services to Carbondale, Illinois, because of the state's laws in Tennessee. But she is running the first ever Black Midwifery Fellowship out of Choices in Memphis. And so she's quadruple. And it's pretty cool because 3 of them used to be IBCLCs, right? They started their careers as IBCLCs. And one of the things that she has done is really created a wraparound service. So she has midwives and doulas and lactation consultants all working together to wrap around the Black birthing community in Memphis. You know, it's 1 million estimated residents there, and the majority of them are Black. And when she started her work almost a decade ago, she was one of 7 Black midwives in the whole state, and she was the only person that had both hospital, birth center, and home birth privileges. And she's quadrupled that now with her fellowship. Hers is a model that we should be investing in. Their health outcomes are incredible. She's going to be presenting some of her work at the Black Mamas Matter Alliance Conference and Training Institute in September in Washington, D.C. Their numbers are ridiculously incredible. You wouldn't think that health-related disparities in pregnancy, birth, and abortion existed when you see their numbers, because it doesn't. Their outcomes are incredible. On the left-hand side, or my right, you will see future nurse midwives. Actually, most of them have become midwives already. We can make investments to diversify our workforce. It's totally possible. And public health researchers who believe in critical race theory and public health practice have shown us the way how to do this. This is a figure from Chandra Ford's work out of UCLA that really talks about why workforce matters and where we should focus our efforts. And I will draw your attention to this conceptualization and understanding contemporary patterns of racial relations. The next panel, I'm very much looking forward to hearing, the work around how this shows up in lactation. But we have always had a theoretical framework to talk about our workforce, to talk about why workforce diversification matters, and why it's both a retrofit and a reimagine. It's a retrofit because all of healthcare will benefit by diversifying the workforce, because we have a larger diversity of ideas, we have a larger diversity of educational pedagogy or ways of teaching. But then it's a reimagine because those individuals will move their educational programs forward, their curricula forward, their research. It's an investment in our futures. So it's both a retrofit and a reimagine. And it's super important we begin to think that way, because that changes the kinds of decisions that we make. So my take-home points here are this. Roles within healthcare matter, but power and its distribution is not universal in health services provision, and we have to start thinking this way, right? Our physician colleagues have got to understand that we will no longer tolerate healthcare hierarchy, right? People's lives are at stake here. And they have a very essential and important role to play in health services provision, but they are not the end-all, be-all. And we can't ever fix systems without fixing the humans that work in them. This is why when people always tell me, Dr. Mclemore, we need to work on structural racism and we need to do this. I said, well, how are we going to work on structural racism? And I love Kamara Jones. She's just been at UCSF as a presidential chair for the last year. We have to work on interpersonal racism and structural and or institutional racism at the same time, right? You can't, this is where the both and is really important. You can't do one without the other, because somehow that's how you end up with people who think that they've done their implicit bias training, and somehow now they have the skills necessary in order to be able to stop reinforcing structurally racist organizations and institutions, right? It's both and. So how does all of this, right, relate to the operationalization of reproductive justice in the context of lactation? Well, the first thing I'll say is this. We're not going to get anywhere until we can get folks to recognize from a human rights perspective that the only real arbiters or decision makers of any pregnancy outcome is the pregnant person and the constellation of people around the pregnant person. Whether that's their God, their clinician, the co-parent, grandmama, whoever it is, right? They are the only true arbiters of what risk people should and should not assume, right? They are the only people. You are talking about a lifetime commitment. It's not just 18 years until somebody becomes an adult, right? You are talking about transitions in people's lives. Somebody asked on the Hoover app Can you please explain, Dr. Mclemore, advising our clients in the context of the Dobbs and strategies when we're working with community members about the overturning of Roe versus Wade? Let me say 3 things about that now. The first is we have too much criminalization of Black people. This was before this happened. So for all your people who don't understand digital privacy, please get people to understand that I would really recommend, strongly recommend, you minimize use of, and this is going to sound directly in conflict with what I said earlier, around social media. However, the case in Nebraska is depressing. And if you don't know about it, Facebook was forced to turn over Messenger conversations, and mom got arrested around their daughter's abortion in Nebraska and using Facebook Messenger posts. So digital privacy is really important. If you have a pregnancy decision to make, regardless of whatever it is, please don't post it on social media. Don't use pregnancy apps, right? Because it's really important. The second thing I would say to people in this room is please make sure you know where fact-based information is and where you can get it. Because right now we have crisis pregnancy centers in this state where we are, and 13 others that are actually receiving more federally funded dollars and state dollars than actual public health departments. This is also true in Ohio, in Texas, Indiana, right? Your crisis pregnancy centers or your pregnancy health centers are receiving more federal and state dollars than actually public health departments. So we really want to be able to spot and identify these centers for the people that we serve. And don't get me wrong, I'm a both and. Those centers do some real good stuff that I think members of the state and federal government should be doing, right? I mean, our people we serve, they know if they need a good car seat, if they need diapers, if they need things, they will go sit and listen to those lectures if they have to be able to get those things that they need, right? So I'm not judging anybody around that. And at some point, we as a community need to go talk to the crisis pregnancy center people. Folks thought I was crazy when I said this as a nurse, and I conducted one of the first studies in the country, trying to talk with them about what services they are and are not offering. Because I do think they have an essential role to play in this process. And I know that makes me a heretic in some rooms, but I don't really care. Because the truth of the matter is pregnant people are seeking out their services, and they are savvy enough to know what they need. And so if we really trust patients as experts by experience in their own lives, then we will trust them to be able to, get the material things that they need. That said, they still need access to evidence-based information, and that's where we play a really important role. The third thing I will say about this whole situation around Dobbs is let's remember that we have spent too much time studying the outcomes of pregnancy and not the condition in and of itself, right? Abortion, birth, miscarriage, infertility, these are outcomes of pregnancy. Pregnancy is the condition. Let me say that again, right? I mean, we spend a lot of time studying the outcomes of the condition, but we don't study the condition. So one of the things we need, we still don't understand, we have theories about this. What starts normal birth? You got some people thinking it's a hormonal cascade. You got some people who think it's aging placenta, right? I mean, but we actually still don't really understand the initiation of parturition. So to think we can understand its outcomes and the complexities that go along with that, particularly given the emotional connection to the fact that it's the propagation of our species, we might want to rethink how we make investments. And that's why keeping your eye on some of the funding sources that the National Institutes of Health are currently trying to do around the IMPROVE initiative and maternal morbidity and mortality. That's why keeping your eye on the National Academies of Science, Engineering, and Medicine. This is not a commercial from them because I'm not a member, but I will tell you that they are asking for public comment on what federal policies contribute to racial and ethnic health inequities, and the public comment time is due September 30th. There's an open meeting that you can register for on Eventbrite, which is September 9th, to make public comments about what policies you think are contributing to racial and ethnic inequities in health. And one of them I would say is this default stance that lactation is an add-on service that's by consult or referral when there is a problem, and that we do not reimburse, compensate, and or fund or invest in these services proactively from a preventative perspective. So, for me, it's this bigger discussion of we have to use our existing infrastructure as it still stands to be able to demand better policies, to demand better information, to demand better workforce, to move us towards health equity. If you don't know this exists, this came out right before the pandemic, and it was put together by over 90 organizations. Many of them are represented in this room, by the way, to talk about this blueprint for sexual and reproductive health rights and justice. It was updated before the election to really be able to say that these are the priorities that we want the executive branch to focus on. These are the priorities that we want the National Institutes of Health and National Science Foundation and the CDC, ARC, right, HRSA, all of our federal funding agencies, which I will remind you are funded by taxpayer dollars, your money and the money of the people that we serve. We deserve better. Dr. Chris Perry came to me with a crazy idea and said, Dr. Mclemore, we need to have a call for the White House. We need an Office of Sexual Reproductive Health and Well-Being. I said, yes, we sure do. Let's get that. Right? And we thought we were going to be able to work with the Office of Gender Policy, which was at the time called the Gender Equity Policy, to really be able to make some great strides in this area. But we've been doing nothing but retrofitting and putting out fires. What would it look like to dream in lactation? What would you ask for? If Mackenzie Scott rolled up to this room and asked Rose, I want to give y'all $300 million, what y'all gonna do? I'd be like, here, look, I got me a list that we gonna do this and that, right? What would you do? The first thing we would probably do is cancel all the student loan debt, all of it. I never had any student loan debt, just to be clear, right? I went to 3 public schools and taxpayers used to fund public education, so I'm one of them lucky people, but I'm on team, let's cancel student debt, right? The other thing we would do is we'd probably create debt-free scholarships to train more lactation consultants, right? How many people in here will open your own consult service or your own business, right? How many people would improve your online capacity and your telehealth capacity? We have to unlock the creativity of what we would do differently while we're building the path to get there. Does that make sense? Because I can just tell you, one of the things that I'm going to be unrelentless and real rogue about this, we are still in an opportunity like we were during lockdown, right? Remember during lockdown when all sorts of rules got relaxed? I've been a nurse for 32 years, right? So it was real interesting for me to finally see nurses and physicians being able to work across state lines. We've had national licensure since the beginning of time, right? The only place that you could cross state lines was in the military. But all of a sudden, somebody said it was okay to change the rules, and the rules got changed, right? Just like how many people was working on telehealth long before the pandemic hit, and then all of a sudden CMS was like, we're going to pay for telehealth at the same rate we do in person. We've been working on that for years. And somehow the rules went back. How can we make them go forward again? What's the levers that we need? What's the coalition that we need in order to be able to make that a thing? Those are the kinds of reimagine and reformation ideas we need to be thinking about. And then who are the partners that we need in the room to be able to make that happen? That's another reason why workforce diversification matters. Because when you have people who have different lived experiences prior to coming into health services provision, they have new ideas about how to do this work. For the people who online, I see your question about what are the doable actions we can do right now. Well, first of all, I said this before the Roe decision came, when the leak decision came out. I'm going to keep saying it. We could have guaranteed the employment of all the workers who currently work in abortion, contraception, and family planning if healthcare had stepped forward and said, all those people are guaranteed to have a job, and we will see none of those folks on the unemployment line. You know how important that would have meant to folks? We can still do that. We can commit to ethics training of all workers to not surveil our patients nor racially profile them in their medical records or other documentation, because it goes against at least the American Nurses Association Code of Ethics and our interpretive statements. We're not agents of the state nor the extensions of the police. We can consider training to staff to provide accurate and evidence-based information regarding all pregnancy outcomes. We can demand transparency specific to pregnancy health and crisis pregnancy centers, what service they do and do not offer, whether or not they're clinically licensed or not, whether or not they have licensed providers on site or not. These are important questions, because regardless of what pregnancy decision you're going to make, it is time sensitive, right? We might as well throw that early entry and late entry to prenatal care as a metric out the window, right? I've said this in public health, people get mad at me, but seriously, y'all? You have people driving across state lines and doing all this other stuff. Because it sets people up to be blamed, again, for their pregnancy outcomes. So as a scientist and a data person, yes, it pains me to say that, but we need to take that out as a metric, at least in our current environment, because the data are going to be off anyway. We need to work with academic institutions to lead and design research that is relevant to our current climate, right? We can't just document the harms of the loss of Roe. We want to take a harm reduction approach. We want to document the innovation, the mutual aid, right? We don't just want to keep reifying the same, question. We need to demand new variables from data sources. Perceived competence, perceived confidence, right? Y'all know what that is. Whether you call it that or not, you know when someone is trying during lactation. You know when they've made progress. We need intermediate, not are they breastfeeding, yes, no, right? And how long? There are intermediary things we can do. What is their perceived competence? Do they believe they can do this, right? What's their perceived confidence? I got this. Have they made improvements, right, over time? What is their knowledge and their interest? Can they articulate that to others, right? We need other metrics. We've been lazy as researchers and scientists. Consider social media use. I mean, all the young people I work with, I'm telling you, man, they keep saying, Dr. Mclemore, are you going to get on TikTok? I was like, are you kidding? It's enough for me to keep up my other channels now. Are you kidding? But I've seen some good public service announcements on TikTok. I've seen some bad ones too, don't get me wrong. But I mean, tools need rules, right? We have to use these tools because the people we serve are using them, right? So I'm gonna give me some help. Somebody gonna help me with some TikTok situations because, it is one of those situations where we have got to reach people where they are. We say that, but then we don't do it. I can't tell you how many public health departments want me to look at their brochure. I'm like, seriously? You still printing stuff? Right? I was like, you ain't got no app for that, right? I mean, so we need to be thinking about those things. Right? And this is another place where Dr. Asiatu has been vanguard in social media use around lactation groups, right? We need to be thinking, where else can we be reaching people? Got to partner with our local doula group. I was, reborn as a nurse. I say this, I was reborn as a nurse when I met some doulas who really taught me that I had lost a lot of my skills as a nurse. I mean, it was graceful when they said it. There's right though. Right? And I mean, so for me, my first go-to people for wisdom and knowledge and insight are doulas. I am working to make sure that, IBCLCs and lactation consultants are also included in that. Because I am really starting to learn and understand that as a nurse, the things that I do, I have a very unique skill set. but it's irrelevant outside of a team. Right? I want everybody in this room to plan to become the employer of choice for people who previously received services in your program. Can you imagine if that was an outcome metric? What percentage of people you previously served are now your current employees? I'd be like, what? Right? Think about that. We have enough faith in the futures, and we have enough faith in the people that we serve, that we want to become the employer of choice for them. Right? I mean, how many people would put down this money down today and say, in 15 years, 25% of my workforce are going to be people we previously served? Right? We have to develop the courage to do our work differently and then act accordingly. There is brilliance in this room that has yet to be unleashed for a whole variety of reasons. And I think collectively, we can really do some brainstorming. We can really be thinking about some innovative new programs. I remember when we started the doula program in 2013, everybody and their mother was like, oh, you're never going to get a doula program federally funded. Oh, what's a doula, right? And now it's on everybody's lips. Panacea for resolving maternal morbidity and mortality, right? Forcing them to fix a problem they didn't create. Anyway. So here's my final points, and then we're going to open it up for some questions because I want to have some dialogue and be able to get to some stuff that I know is going on in the app, but I want to be able to be available to you and in service from where I sit. One is we have to use retrofit, reform, and reimagine, or whatever other tool you want to be able to use, so that we can break down some of these discussions and get everybody on the same page so we know what the goals are and we know what we're trying to achieve. We need to distribute resources based on need, as Kamara Jones has stated. And quite frankly, I think that's a workforce development project that needs to happen that really could, it's grounded in this room. I think we need to allow for a divide and success approach. I'm trying to move away from military language, so instead of divide and conquer, I'm trying to go for divide and success. Right? Some of us need to be on retrofit. Some of us need to be on reform. Some of us need to be on reimagine. And we need to know who's where when, and that we got to trust that somebody's on one of them. Because we need all three right now. We have a necessary need for clear articulation and communication. How healthcare hierarchy must die. And we need to stop talking about team-based care and start providing it. We need to share power amongst and between the health disciplines and the health profession. And we need to stop talking about diversifying our workforce, and we need to do it. And then we have a need for community engagement and accountability and leadership. One of the things that I'm really trying to do right now, and I'm struggling as an academic, but I'm going to figure this out, is how do I make opportunities for community leadership? It's one of the reasons why I'm only directing the Center for Anti-Racism in Nursing in an interim role for a year. I negotiated that because I should be able to turn this program over to a community member and a faculty member to co-direct it. My job is to get them the money that they need to run the center. We also need a mission, vision, and values, a logo, and a name change, because right now the acronym, it's Karen. It's the Center for Anti-Racism in Nursing, CARIN. And they was trying to make it caring without the G. But I was like, it spells Karen, right? But yeah, my job in an interim role, because here's the thing, right? Leadership should be shared. If leadership was shared, then we would have more empathy, because everybody knew they'd turn at some point. If we rotated leadership, can you imagine the different kinds of decisions that people would make? If you knew it was temporary and you knew at some point it was going to be your turn, right? So as we start this meeting, I hope I've gotten your creative juices bubbling to really be able to talk about some new ways Rose and Robe and all the organizations represented here are going to make new futures and to make everything we have in the now different.